we have a really exciting panel with some luminaries of the industry. So if I can just take a moment to welcome our panelists for today. I'd like to start with Dr. Vandana, who's Executive Director at Path Labs. She's on the technical committee for NABL, and I don't have words to say. She's a luminary in her field, the OG of diagnostics. So Dr. Vandana, please welcome to the stage. I would next like to invite Dr. Prabhdeep Kaur. Where is Dr.? Oh, she's here. All right. Dr. Prabhdeep is a distinguished. Prabhdeep Kaur. She's a distinguished researcher, professor, focusing on community healthcare systems. Done a tremendous amount of work in public health. Next, I would like to invite Hanno, who just gave an amazing talk. I didn't understand anything, but I'm hoping to catch him during lunch to help him have him break it down for me. And of course, David, who did an amazing talk on inflammation, and we hope to talk to him about how we can use some of these things. Welcome, everyone, and there's mics on the tables for all of us to use. Yeah, so the panel, we realize only in hindsight that we've named the panel very interestingly. It's Longevity for Billions. If any of you are thinking that it's about how do we make billions of dollars with longevity, no, that's not the intent. The intent was how do we bring longevity to the masses. And I'd actually like to start with Dr. Lal. We thought we would start from the science and then go to the masses. But given that we've had enough science, we actually start in the opposite direction. Dr. Lal, nobody needs an introduction to Path Labs, right? You guys have done a tremendous job in bringing diagnostics to almost every nook and corner of the country at really high quality, etc. And how do you see? And you've been sitting through talks. You've been going through all the stalls, etc. Booths that have been set up. How do you see some of these innovations come into like the diagnostics ecosystem from a public perspective, right? What does it take for some of the things we talked about here, like proteomics and information-based aging, etc., to come into the public, like testing, become a part of, let's say, preventive panels, packages, some things that doctors recommend? How do you see this journey playing out? And what's the barrier in terms of, let's say, science, applicability, etc.?
So as you're all aware, India has a big demographic advantage with a population of 143 crores. And but the health-seeking behavior of the people is very varied in the whole country. And we have India divided, this is especially for the Western visitors here. We have India divided into 4 tiers, and the tier 4, tier 3, and the rural areas are just untapped. However, as a company, we have been successful in reaching out to these people. Basically, it is by creating an awareness, education, and also, which is not only for the general public, but also for the physicians. Because of these high-end tests, even the physicians are not aware. They do not understand what is proteomics, what is molecular. So they have to be educated first so that they can understand. The second problem in India is that we are still in the illness region. Moving from illness to wellness will still take a lot of time because they don't understand. Once they are well, they are well. They only seek doctors when there is illness in the family. This awareness, however, has come in the tier 1 and tier 2 cities where the new millennials, as they are called, are aware of looking after their health and doing the wellness diagnostics, but not the majority of the population. 90 crores of the people of India are living in rural areas, which is a huge number. And if this can be tapped through education and awareness, it'll really benefit the longevity program. Second thing is the price. The price of these high-end diagnostics is very, very high. This price, if it could be brought down by lab-developed assays or by manufacturing at the domestic level and not depending on the international companies for supplying us reagents and equipment, would really help. Lab-developed tests doesn't mean that you develop a test, but it has to be validated and it has to be accredited by an external body so that what you are offering to the public is high quality service. High quality, as you're all aware, comes at a price. But by bundling of the tests, you can bring the prices down. And also by the price, certain price has to be absorbed by the company or the testing agency themselves.
Thank you, thank you. That was very insightful. So what I took away was that we need domestic assays. We need to improve awareness when it comes to physicians, because a lot of this is like rapidly evolving. And then how do we get the rural population to participate in this journey? David, you have.
Yeah, I'd like to comment on the last piece. The first discussion around demographics, and that's the reality of things, right? Is very accurate, and I respect that very highly. Now, when it comes to the testing, right? So I agree 100% that we need laboratory developed tests. We have a CLIA lab that certifies that we have validity and that is reproducible, right? I think the democratization of the technology is mostly achieved when you have reimbursement. So when we have demonstrated to the FDA that this has a predictive diagnostic tool for improving healthcare long term, and you have a code, a CMS code, that's reimbursed, it becomes free for everybody, right? Another thing I would like to say is that we're actively working on a different technology which uses facial recognition to predict inflammatory age. So that can be deployed in masses for free. It's an ultra low cost. All you need is your cell phone. So it's one of the things we're developing to democratize the ability to measure at least these inflammatory markers in blood.
David, I have a question for you. In fact, yesterday at dinner, one of the researchers and a speaker was talking about facial age detection. And I think he was talking about some technology in China where millions of people are getting scanned. And he was talking about how the person who developed this herself said that the age is different every day and different times of day. If she slept poorly, the age was 15 years higher. If she slept well, it was lower. In the mornings, it was different. In the evenings, like how do you make sense of this? It goes back again to the point Matt was making about his biological clock being like 20 years apart through these tests. So on the one hand, we see all these new technologies coming through, and on the other hand, there's such a large variation in what they're measuring and how they're measuring it and what they're giving you on any given day.
No, I fully agree, and that's why we have to standardize. Right? We need the standardization. I would claim that if you measure every day around 8 a.m. in the morning, fasting, you should have pretty consistent results.
Yeah.
So that's on the measurement. But predicting aging, chronological aging from the facial, that's meaningless. Why do I want to, might as well lead your passport. We're talking about something completely different.
Okay.
We're talking about looking at that facial features and predicting biological age in the blood. So that's where we're headed. And we have this 1,000 people study that we're pairing facial photos, right, with blood, RNA sequencing, and inflammatory age.
Okay, thank you. Dr. Kaur, I'll come to you because Dr. Vandana talked about rural health, etc. And you have tremendous amount of experience. In fact, yesterday we were speaking about some of the challenges, right? We're talking about longevity here, but even I think there was an example that you gave where even the number of strips for the year in a PHC is heavily restricted. How do you see any of this getting through? What are the challenges that are unique to our ecosystem, and how do we get past that?
Yeah, thank you very much. I mean, I've been listening to these talks yesterday, and it feels like I've been working on a different planet. But I'm happy to be on this planet and learning where the world is going. But what I'm trying to emphasize here is the wide disparities that exist. Wide disparities in many ways, access to health, of course, being the crux of it. but also being able to use the existing technologies, whether it's diagnostics or any technologies. And since you wanted this panel about how to reach the billions, so I'm going to keep my focus on that. So I think we need to make a clear distinction on when we talk about diagnostics. Are we talking about research, or are we talking about technologies which can actually be scaled? So I understand that, some of these may become very scalable in the times to come. Very interesting talks today, and I do completely agree with him that the reimbursement makes a difference, and what kind of technologies are reimbursed either when you have employee health checkup. I'm sure Dr. Lal would have seen that when you have these employee health checkups and the tests which are done, they are more commonly done tests because someone is paying for it. Similarly, the national program now has, for instance, screening for diabetes and so on. So I think we need to make a clear distinction. There are a lot of things that we are learning which are still in the research mode. And some of it may be scalable to a level, like to a certain social groups and those who may have access to those tests or those diagnostics. But a large, I would say, the large proportion of our population still lacks access to very basic diagnostics. So I think we have a long way to go. And if we want to, your second part of your question was what we can do about it. There have been a lot of efforts to improve access to diagnostics. And we are talking about longevity today, but historically, if you see in India, the focus has been more on infectious diseases because we had infectious disease as a bigger health problem. So if you look at the government programs, they have done tremendous efforts in increasing the access to diagnostics for infectious disease. For instance, TB diagnostics have improved a lot. Now we have very good tests like TrueNet available in the most remotest areas. We didn't imagine that when I was a medical student in 90s. We still did not have even basic tests available in most of the India. So what I'm trying to do is, if you fast forward 20, 25 years, many things which we did not imagine have actually reached people, which tells you it's possible. However, prioritization is important, and of course the which are the diseases of importance, and here we are talking about health. So what, are there pre-disease conditions that we should be focusing on, because we can't scale everything.
Yeah.
So we need to prioritize what is that we want to scale and what kind of technologies we need to scale that. And I mean, I've been seeing lot of startups here, and you also talked about, so there are a lot of things we heard about, diet, physical activity, sleep, connections. I think it's been talked. But these are things which we could make people aware that, you could do something around it, which is possibly scalable. And using the tools and technologies to enable that, to assist people make better decision for themselves, yes. But when it comes to laboratory testing, I would say, I'll give a simple example. India has nearly 25% adult with what we call as impaired fasting glucose, which is a pre-diabetic condition, but most do not know about it.
Yeah.
Even diabetes, which is a disease in itself, only 50% people know they have it. And when you talk about a pre-disease condition, it's even worse. So I think we really need to focus on those pre-disease conditions where we can sort of make it possible to get the diagnostics. And the quality is important. Again, there have been a lot of efforts to ensure quality in the diagnostics, but it's a huge challenge when you get to the rural areas, and I'm sure Dr. Lal is aware of that. And public-private partnerships are needed to improve the access to diagnostics across most of the countries. And I think another, from a policy perspective, I want to highlight this. Like now we have insurance program which covers for hospitalization.
Yep.
But we actually need programs which cover for preventive health checks.
Yeah.
So even if people get it done in, let's say, in the empaneled labs or in the labs which are of high quality, they are able to get it reimbursed. And last point I want to make is, I really like your talk in terms of system thinking and longitudinal tracking. And I think that is something doable. We have large-scale government programs which track people, their health parameters. And if we can use technology to actually do it in a better way, so that we are not just, filling, the healthcare workers have to write so many registers and so many papers. They are keeping track of, large number of billions of people with those paper-based records. And if we can do good low-cost technologies, I think we will be able to make a difference. Thank you.
That's a great point. Hanno, you had a comment to make?
Yeah. So as a disclaimer, so I'm not, also based on my talk, I'm not proposing to use mass spec as a diagnostic tool. We try to discover biomarkers, which are then hopefully turned into some antibody-based test, for instance, which are then can be used much more easily, because a mass spec is just an unwieldy, expensive thing to run, so you don't really want to do that. No, but listening here to this conversation, I think we have to differentiate at the moment a little bit more than just talking about diagnostics. After all, I think a biomarker for sick care is quite different from a biomarker for healthcare. When kind of prognostic, at that moment, the time requirement can be quite different. If you have an acutely sick patient there in the ER, you need a result very quickly.
Yep.
And also the sensitivity, the specificity requirements are very, very different, or the implications if you make a mistake is quite different from kind of, hey, measure my molecular A or my kind of, based on the molecular clock where I am, I can always measure the next day again.
Yep.
And also then, for instance, standardization is very important. But when it comes to diagnostic in the ER, the people come into the ER at any time of the day. So anything you develop has to work 24/7. It can't only work at 7 o'clock in the morning, the second void in the morning or whatever. So I think one has to be a little bit, one has to differentiate there a little bit. Now back to the kind of original question, how to democratize diagnostics. I think one important point is also really the sampling. And I really only kind of, my last statement on my conclusion slide is we have to come up with other sampling methods that are more easily done. And obviously it would be great if imaging would work, but I personally think that any kind of dried blood spots or something like that can be remotely collected, put into an envelope, and then shipped to a central lab.
Hanno, can you talk in a little more detail about dried blood samples? You know, you've been talking about it. You know, how does it work? What does it mean? What can you do with it? What can you not do with it?
Actually, so dried blood spots, it's a special filter paper. You prick your finger, or when it comes to newborns, they prick the heel, and you kind of squeeze some blood blood drop onto this paper, and the water content evaporates relatively quickly, and then basically the proteins, the metabolites, everything that was in blood is then pretty well conserved on this filter paper. And we recently had 2 studies. One study where the samples were collected between 5 and 25 years ago, were stored in minus 20 degrees freezer. And we couldn't find a single protein that would correlate with the age of the card. So it's really kind of, it tells you that at the proteomics level, they are rock solid. Okay, that's nice, minus 20 degrees, but even in rural areas, robust minus 20 degrees freezing is a difficulty. So we had another cohort where the samples were literally stored on top of a shelf for years at room temperature in South Africa, so not necessarily the best temperature or whatever. And also there, it's kind of, those samples look the same as if they were stored at minus 20 degrees. So I'm not sure whether they fully understand how this dried blood spot, how it conserves everything. People have even done enzymatic studies on these dried blood spots. But in my think they're really kind of magic, because they really conserve a lot of the activity, and certainly also the proteins, metabolites, and so on. And those are really, the nice thing is really, everybody can collect it at home. You pop it into an envelope, you give it to the mailman, and they can ship it then somewhere else at room temperature. You don't need collection. So for instance, this newborn study that I showed, those samples were collected in Papua New Guinea and in the Gambia. And just to ensure the blood sampling, the minus 80 degrees freezer, the the dry ice shipment, we are talking about $50,000 just for the sample shipment and so on. If we had done dried blood spots, which would have been good for proteomics, obviously you can't necessarily do PVMC work and so on, it would have been $500 for the shipment.
Yeah.
To add on to that, I think this is a very important point, and as you know that for anemia, very big problem for India, and dried blood spot has been tried. So I think we need it for more biochemical parameters for sure, and even I think we also need more point of care tests which are of high quality and comparable to the best. So for instance, there are many startups even in our own campus which are doing that. But it's not enough. We just need many more of those products in the market which are scalable.
Yeah. In fact, I'll take this opportunity just to talk about one. There's this company called Neodox, and they're basically making these reagent strips. They're starting to do, again, it's not as high fidelity as, let's say, taking a blood sample, sending it to a lab, running an automated test on it in a machine. But it's point of care. It's a card. You basically put, it comes fully contained. So you take a lancet, you take a small blood sample, and you can measure hemoglobin, you can do CKD. And again, if you start to do it every day, you can start to see trends, etc. And it's very, very accessible from a cost accessibility perspective. You don't need a high quality lab running in the city. So there's a tremendous amount of work happening here in our backyard as well. David, I'll come back to you. You talked a lot about inflammation, and I think in the last few years we've started to see this increase in conversation around inflammation. Something that used to be like today. I think most people here would probably know what their HbA1c scores are, at least here, hopefully in this audience. I don't think most of us know what our inflammation scores are, right? And then, if I remember correctly, you also talked about how IL-6 is not the right thing to measure. I don't know if it was in your talk or one of the other talks. So my question is, does inflammation need to become mainstream in terms of diagnostic conversations, and how do we get it there? And then I'll turn it over to Dr. Lal as well to talk about how does inflammation become mainstream?
Yeah, a great question. I think it should. It should become a measure that you do as a yearly checkup, as you do your cholesterol.
Yeah.
Because it's so important for the development of a variety of diseases, and we know that already, right? We have 5 biomarkers, as I mentioned before in my talk, that when combined can give you a test that predicts morbidity,
Yep.
cardiovascular issues, immune health, mortality, and so I think it's so critical. The issue is to bringing this, again, FDA in the US, right, and make that available for everybody. It's a big leap, right?
Yeah.
But I definitely think that once we cross that leap should be included in every single hospital out there, because it's so critical and everybody understands that. Or maybe I'm biased, but I think most people understand that inflammation is a big factor in developing almost nearly any disease.
Yeah.
So,
Dr. Lal, any thoughts on the topic?
So it's, to penetrate the market, you need a low price. You can't be selling tests at a very high cost to the patient. And this you could actually make it happen if you have the volumes. And how we have penetrated the rural market is by creating awareness in the local language. India has a big problem of everybody doesn't understand English or Hindi. They have to have their local language. So you have to create awareness in their local language so that they get the test done. You can, by creating volumes, the cost will automatically come down.
Yeah.
Also, to create awareness, we have used the National School of Drama to create, we call it Nukkad plays, which is street plays, because the people engage when you have some activity which entertains them. And once they get entertained, it creates an awareness. So these are various ways you could introduce inflammatory markers and other big high-end tests. However, like I said, you need to have these tests being made in India for us to promote them so that the price comes down, because our dependence on the Western market is too much.
Yeah.
We want to reduce that.
Yeah.
Other way is that in India, we have nearly 800 districts, and Ministry of Health has announced opening medical colleges and hospitals. 50% of it has already been achieved. So if we work through the PPP model, which is the public-private partnership, these tests can be promoted. The government can bear some of the costs so that the patient doesn't have to bear it, and the longevity program becomes successful.
I think any novel marker or test to come to a public health program, I think we have a long way to go.
Yeah.
It can be introduced once first of all, the science need to be very robust. That's important, and I don't think we are there yet in India in terms of inflammatory testing. I don't know, there might be some doctors here. We used to do ESR test,
Yeah.
long back for every fever case. Okay, so I do understand that this concept has always been there in medical practice, that we need to look for inflammation. But unless we have tests which, and it's not just about the tests being affordable, and we also need to make sure that if we do these tests and we do some intervention, there is a benefit, and we need to demonstrate that benefit at scale.
Yeah.
And only then I think we will be ready to take these tests to our programs. Thank you.
I have so many questions, but we are running out of time. So I'll ask one last and maybe take a 10-second take from everyone. You know, as I've been sitting through these presentations, we are talking about years to get anything out. Everyone's talking about 3 to 4 years to do this. I think Dr. Siddharth talked about 3 to 4 years for his next set of things. How do we accelerate things in healthcare? Is it just the nature of the beast? Or is there something we can do? I mean, we have academia, now industry, and lab, public health. How can we just accelerate some of these things? Why does it take 3-4 years? Can it take lesser amount of time?
I think we should start with them. They are the ones working.
That's a
I love it.
really
They are the
hard
problem
one.
here.
It's a hard question. I would say probably more funding. More funding, we get more people, we get more hands, not less funding, like it's happening today
right now.
in the US.
Clearly, you guys are not working
Quite the
hard enough.
opposite, quite the opposite. So more hands, we can accelerate the research. As simple as that. That's at least my take.
Well, obviously more money would be nice, but let's face reality. So my approach was more, let's try to commoditize what we are doing. And if I think back 15, 20 years ago when I started my lab, the value proposition was basically the omic analysis. That was the special thing, the secret thing, and the sample was just something that one got. But I think by now, omics has gotten so cheap that the valuable part is really the sample now. And I think that's also where, from a proteomics perspective, we can now do those large-scale studies which are much, much more meaningful. And I think that's really important, that the omics becomes very cheap, because there are a lot of samples out there that we could do. And now I think it's the time also to really step back, really analyze those population-wide studies, as they've done with the biobank in the UK, with Olink, for instance. And I think now is the time to do this, because very important is also, whenever we talk about biomarkers in disease, we first have to do the normative studies. We have to define what's normal before we go for the one that is negative. Boy, that was a long 10 seconds.
Dr. Kaur?
Yeah, of course, we have one of the lowest R&D funding in the world. So funding is definitely needed. But I think not just funding will solve the issues. We need prioritization and much closer interaction like this, what is happening today with industry, academia, and all the stakeholder, government, and all coming together. So there is rapid exchange of ideas and moving to action, from prototypes to actually doing large-scale testing and scaling.
I think we have to work at the grassroots level to change the attitude of the public towards health.
Yeah. No easy answers. Someone wants more money, which Trump is unwilling to give. So I'll leave it at that. But my takeaway is, again, thank you so much for the panel. My takeaways from this panel are, again, Dr. Lal, love the fact that you're talking about democratization and actually bringing tests to India, doing lab-based assays to bring the cost down. Dr. Prabhdeep, great point on, sorry, I keep messing up your name, but great point on the challenges that we face just in terms of, healthcare, and India's focus on infectious maybe it will take some time for us to get warmed up on the preventive. Hanno, of course, proteomics and how the values now come to samples, and there's so much more to do. And I had questions on biobank also, but we have run out of time. And then lastly, David, thank you so much on the information part as well. If there are any questions from the audience, maybe we take one question and then we'll close the panel. Whoever gets the mic first is the lucky winner.
Thank you. So it's been a great talk.
We'll come to you also, Dr. Soin.
Listening to all of you, I've been wanting to ask this question to David since morning. I'm a geriatrician and an internist, so I see the young and the old. And the markers of inflammation that you mentioned would be great to predict frailty and multimorbidity in my patients. But one thing I find very difficult to understand in my clinics is the conflicts I have with these tests. Many of the younger population these days, they have a little sore throat. They would just go and get a whole battery of tests. And these tests would include a lipid panel, HbA1c, thyroid, anything and everything on the earth. And there you would see one thing would be abnormal, that's called MPV. And they would ask me, what is that MPV? And I would have said, no, I've never measured that in my life. That's like mean plasma volume or mean platelet volume. Mean platelet volume perhaps. And I would want them to get a throat culture because I want to see if it's a strep throat. But they would tell me, no, that is like 3,000 rupees. But this was free from my company, so I got this entire panel. And every time I see these battery of tests for iron, strontium, lead, beryllium, you name it, it's a whole battery of tests. How do I interpret it? They're asking me to pick out that one particular disease when this one lab value is abnormal. And these are all pretty young people with a lot of fear and stress of what's going on. And I cannot really tell them what's going wrong with them. And I think the medical schools should be talking to all of you, and kind of there should be an integration of the medical curriculum, because we clinicians are the ones they come to with these abnormal tests, and I'm really helpless, and I really wonder if I should have studied medicine.
We take Dr. Soni's question as well, and then maybe answer both in one.
We can debrief later.
Yeah, thank you very much, all the panelists. Really enjoyed the interaction. I have a few comments on democratization of both diagnosis and intervention. So the Indian government actually has a national program on prevention of non-communicable diseases in which they've included non-alcoholic fatty liver disease, or just fatty liver as we know it, because as we know it's connected to obesity, diabetes, cardiovascular disease risk and all that. So the diagnosis for metabolic syndrome can be made on anyone in any village. It's just got blood pressure, waist circumference, blood sugar, lipid, two kinds of lipids which are measurable by, like Gaurav pointed out, by a point-of-care device. You can even do a HbA1c with a point-of-care device. So it's actually possible to reach the masses with the basic diagnosis of metabolic syndrome. And that, as you know, is at the center of causing all the chronic diseases and longevity. So that's one comment. The other is that it is possible to mass promote and reward positive health behavior. So by that I mean, cessation of smoking, alcohol, having universal insurance of some kind or the other, and also inducing insurance companies to cover preventative health, because the majority of them don't do that nowadays. So those are my 2 pennies about what you said.
So we'll start with the clinician's question first. Like, why are you creating all these tests that...
Yeah, I think most of the pollutants in the air, the things that we're exposed to, that you can actually measure from blood, ultimately trigger inflammation. Even metabolic syndrome will trigger inflammation, right? And so if there's one, and again, take it as a grain of salt, I'm biased, I know I'm biased, but the research shows that many of the exposures that we suffer from that cause different derangements in your body are through, work through inflammatory processes. So if you have to measure one thing, I would say let's measure inflammatory age and bring it to India. So that's my 2 cents there.
Thanks. If I may ask one last question to David Furman. What are your top 3 daily practices to delay aging so we can all practice the same?
Actually, I'll modify that question. Reduce inflammation.
Yeah. So okay, so this is maybe a 10-hour discussion, okay? But I'm going to make it very short. Any species that is moved to a new environment will develop inflammation. And we are not in our ecological niche. So think about it that way. Electrical light, being sitting in a chair, gluten. We didn't evolve with these things. All the emulsifiers that were discussed previously, they wipe out your microbiome. We have a very reduced diversity of microbiome. Plastics, we're breathing plastics that are accumulated in the brain, in the heart. So try to avoid all those things. Pesticides, they're hormonal disruptors. They trigger inflammation. We know that. And so the list is very, very vast. What do? Well, I try to avoid those things, minimize those risks. Just give you one example, a single example. My toothbrush. It's boar bristles stick it in this wooden stick. Right? It's a commercial one, right? But there's no single plastic in that toothbrush. Just one example.
All right, thank you for that. Thank you so much. I'd like to thank the panelists, and they'll be available in case you have further questions. Thank you so much.
Thank you very much.